When preparing and identifying the equipment used for laryngoscopy and iGel insertion, it's advisable to use a clinical waste bag to form an airway kit dump, and also ideally you would have an airway assistant to help you prepare your kit and then also to help with the insertion of the advanced airway. In clinical practice, we would always keep all of the items within their sealed packaging just until insertion into the patient. However, for demonstration purposes in the education department, we're not going to be doing that. So when selecting your equipment for your airway management, or if you're an airway assistant who is helping somebody else, it's important to have all the equipment laid out ready before you start to manage that airway. So identifying that you've got both sizes of laryngoscope blade available, you have something to secure the airway, you've got your 3 different sizes of iGels available, your catheter mount with filter and end-tidal CO2 attached to the end, some lubrication for the iGel, McGill's forceps in case of foreign body airway obstruction, and an orogastric tube, which is to be used for registered paramedics only. It's very important that when preparing the equipment, we ensure that the capnography is inserted into the LifePak 15 prior to placing it onto the patient in order to give it time to initialise and set itself up. Now that the solid line is visible, I know that my capnography has been initialised. The indications for placing an iGel is that it forms part of our stepwise approach to airway management. An iGel is an advanced airway for the purposes of advanced life support, and it has the benefits of being quick and easy to insert. It does have some limitations in that it isn't completely risk-free from aspiration, and if the patient isn't in cardiac arrest but is deeply unconscious, it could raise intracranial pressure or stimulate the vagus nerve. Prior to inserting the iGel, it is essential that we view the hypopharynx first to ensure that the patient hasn't aspirated anything before we insert our airway. What I'm going to do first is clean my hands and pop some gloves on, and also very importantly when we're managing an airway is to have some eye protection and face protection on as well. For the purposes of demonstration, I won't wear the mask. So I want to make sure first of all that I've got my patient positioned in the correct way. So it's really important that we have our ear in line with the sternal notch. So in a lot of cases, that does mean raising the patient's head slightly so that they're in that slightly extended position, sipping out of a full beer glass. For most cases, this does mean popping a bit of padding underneath the patient's head to get that alignment. And in this case, if I come down to the side now, I can see that the earlobe is in line with the sternal notch, so I'm much happier in this position. Making sure again that I do have my face protection on, I'm going to select the laryngoscope blade that I require, and in this case I'm going to go for the Mach 3. Again, just double check that the light works, and I'm going to hold it in my left hand. I'm going to open the patient's mouth gently with my fingers and insert the blade on the right side of the mouth, going in gently, being careful not to knock the teeth. As I advance the blade, I'm going to sweep the blade and the tongue over to the left-hand side so that I get my blade in a central position. As I advance the blade, I want to take note of the anatomy so I can see the uvula at the back of the throat. I've got my tongue, obviously, I can see my teeth, I can see some of the tonsils, and as I continue to advance the blade gently, I will be able to see the epiglottis, and once I can see the epiglottis, I can ensure that the blade of my laryngoscope sits inside the vallecular space. Now that I'm in the vallecular space, I can direct my hand forwards and view the hypopharynx. If necessary at this point, I can suction or I can use my McGill's forceps to remove any fluid or foreign bodies. Once I'm satisfied that the airway is clear, I can then place my iGel. So selecting the correct size for the patient, and this patient is a small adult, so I can see on the front of my iGel that a size 3, 30 to 60 kilograms is appropriate in this case. I will select the iGel, apply some lubricant to the iGel casing and lubricate the backs and the sides of the iGel. Reassessing my patient to make sure that they're in the correct position. I've now got my lubricated iGel. I'll take a firm grip of it along the integral bite block. Apply a little bit of gentle downwards pressure on the patient's chin, opening up the mouth slightly, and insert the iGel following the hard palate in one swift movement until definitive resistance is felt. I can now connect my catheter mount, the filter, and the capnography to the iGel and my bag valve mask, which is connected to 15 litres of oxygen. Once this is in place, I can ask an assistant to ventilate for me while I auscultate the chest. When I'm satisfied, I can attach my Thomas tube holder. Assess my capnography and ensuring that I've got the reading that I require and a box waveform, I'll print this out. Registered paramedics are also permitted to insert orogastric tubes. These can help with any distension from air from hyperventilation which might be in the stomach. The orogastric tube needs to be measured midway from the xiphisternum to the umbilicus, up to the patient's earlobe and across to the top of the iGel. Make a note of that reading there and apply some additional lubrication onto the top of the iGel port. This can then be fed through to the measured length. Once in situ, the orogastric tube may drain some fluid. If it doesn't drain any fluid, we are permitted to attach the suction onto the end and gently suction fluid from the site if required. When managing the patient with the iGel in situ, it's important to keep an eye on the capnography to make sure that we haven't lost our reading and to ensure that we've still got adequate chest rise when ventilating. If we suspect that potentially the iGel has become dislodged, maybe there's an air leak, maybe we've lost our capnography, it's very important to correct this as soon as practically possible, removing the iGel and reinserting.